I'm Dr. Alexis Chesrow. I am trained as a urologist, and I've also done subspecialty training in female pelvic floor medicine. So what that means is, as a urologist, I've done a year and a half of general surgery and 4.5 years of in-depth urologic surgery in my residency, as well as time dedicated to clinical research. I then additionally pursued fellowship training in incontinence and female pelvic floor medicine with Dr. Gary Leach out in Los Angeles. So my interests lie more specifically in incontinence procedures, prolapse procedures, and I'm currently published on how to repair prolapse without the use of surgical mesh. So we're going to talk about a couple things today. We'll go over briefly incontinence, the various main forms of it, and what can be done, as well as what to think about if you're considering pelvic organ prolapse repair. And additionally, we'll touch base on mesh, which has been in the news a lot recently. First topic is incontinence. And what I tell my patients is there's two main forms of incontinence I want you to worry about. One, it's your bladder's fault. The other one, it's the muscle that holds your urine, it's fault. We always pick something to blame. And you can have issues with both, but in general, we pick one to fix first, and then we go from there. So the first one is when you cough, sneeze, or strain, and you have a little muscle that holds your urine in. And through natural aging and childbirth, that muscle can get weak. So when you cough, it pushes down on your bladder, or you get out of a chair, or you lift something heavy, or you exercise, and that muscle isn't strong enough to hold the urine in, and you have leakage. That's called stress incontinence. And you'll see on TV ads for pads and whatnot to treat that. The main treatment for stress incontinence is surgical, and we'll go over that in a second. So the second form of incontinence is called urge incontinence, and that's the ads you see on TV for I gotta go and I gotta go, or when you feel that you can't make it to the washroom in time. And the reason for that is you forget your bladder is a muscle, just like anything else. And if you've ever had a Charlie horse in your leg or a cramp somewhere in your body, think of urge incontinence as a bladder cramp. And your bladder is a sphere, a ball. And when it cramps, it gets smaller. When it gets smaller, that urine has to go somewhere, and usually that's out. And that typically happens when you least expect it. You can get very little warning, or typically what a lot of my patients see is the second they get the key in the door, their bladder decides that's close enough, and you leak. So urge incontinence is treated very differently than stress incontinence. Urge incontinence is mainly treated with medication or nerve modulation. All right, so let's start with stress incontinence. That's the leak when you cough or sneeze, or muscle weakness. So we have to get that muscle stronger or give it some support. And there's three main ways to do that. One is exercises, and we've all heard about Kegels, but what I tell my patients is it's very hard to do a Kegel correctly on your own. So we actually have, and insurance pays for, because it works, pelvic floor physical therapists. And think of working with a pelvic floor physical therapist as like having a personal trainer. It's like working out with Arnold Schwarzenegger. It'll get you results. And I typically say it'll get you about 50% drier if it's appropriate for you. So the next option for stress incontinence is to kind of make the urethra a little stronger. And if you think of the urethra as a tube, it kind of is not the best analogy. The urethra actually should stick together. It should be on the inside, like two wet pieces of plastic that are touching and therefore sealing shut. As we age, sometimes the urethra gapes open and it's easier to leak. So in the office, we can look inside the urethra with a camera and do a little injectable. Just like you have collagen to inject into your face or your lips, we have material that you can inject into the urethra that plumps it up, so to speak, and helps it close better. This is an office-based procedure. It has excellent results, and it's very safe. You don't have to take time off from work. You can take all of your normal medications, and you can go back to your usual activity and drive yourself home thereafter. I do stick you with a needle. None of my patients have minded so far. So the last treatment for stress incontinence is the one you've probably heard about more specifically, and that's the sling procedure. That is a surgery, and that's where we take a little piece of surgical mesh and think of it like a hammock. It goes under the urethra and supports it. This is a very quick procedure. The incision is in the vagina. It's only about a centimeter or two. And it truly is the gold standard for curing stress incontinence. But it's nice to know we have two non-invasive approaches, pelvic floor physical therapy and intraurethral injections, available for women who don't want a formal surgery.